thank you to Julio for organizing this lovely group of people and giving me the opportunity to rapporteur today. So I think 30 years into the epidemic and 15 years into ART, this is a really exciting time. In the next 5 years, we're going to have answers to a lot of important questions about biomedical prevention. Don't let the slide distract you. I actually didn't want to show these. Right. I'll tell you when I want to pull up the slides. Okay, sorry. It's supposed to be a joke. All right. So anyway, what I was saying is that I think it's a very exciting time because within the next 3 to 5 years, we're going to have a lot of results, both about PrEP and microbicides, and very exciting results, hopefully. We're waiting for the data on a lot of trials about treatment as prevention, both domestically and internationally. So I think it's a very exciting time. I wanted to share one other research study that hasn't been mentioned yet that's ongoing that's going to help us answer some questions about how best to engage and retain and re-engage people in care. So through the NIDA Clinical Trials Network, Project HOPE study CTN 0049 is a 3-arm RCT that's going to be looking at a patient navigator plus contingency management with financial incentives versus patient navigation alone versus standard of care treatment as usual in 10 high prevalence cities in the United States. And it's going to be looking at the population of hospitalized inpatients with substance use issues, not dependence, because we all know, those of us who work on the inpatient setting know that a lot of the folks who are hospitalized have substance use like binge drinking or just minor crack use, like one time in the last year is shown to be associated with poor outcomes and being hospitalized with opportunistic infections. And two of the two PIs, Lisa Metch and Carlos Del Rio, are here. And I just wanted to highlight that study because it's going to give us some important information about how to operationalize improving engagement and care for that population. But while we're waiting for this data, and now you can show the slide. While we're waiting for our data in the next couple of years, I wanted to start with kind of a consideration of how we do scientific analysis in the real world. So let's say that you wanted to calculate how long it's going to take a cow flying out of a plane, going at a particular speed, and you know, when is it going to hit the ground and where is it going to hit the ground? You remember these problems from math and physics class, right? Well, the first thing you need to do is assume that the cow is a perfect sphere in order to do this calculation. But we really shouldn't let perfection be the enemy of good, because while we're waiting for near perfect data, people are dying. And in San Francisco, what we have done is evaluated the observational data that is available. And we had a policy that we instituted last year for the universal offer of antiretroviral therapy in all the San Francisco Department of Public Health clinics and initiated at Ward 86 at San Francisco General, because in the words of our prior commissioner, Mitch Katz, we don't want to have a 2-level system of care in San Francisco where people in the private setting had access to ART regardless of T-cell count, and we didn't have the same access for folks within the public setting. Now, we're able to do this in San Francisco for a variety of reasons. One, strong political will, strong financing by Medi-Cal and ADAB, but also because of Healthy San Francisco, which allows us to take care of all San Franciscans regardless of documentation or immigration status. So just to tell you a little bit about what's been happening in San Francisco, you know, we are also able to maximize and observe what our interventions at the public health level are doing even prior to implementation of this policy. So this is kind of a complicated slide, but it's really meant to symbolize the continuum of care, or the cascade of care that everybody's been referring to, from testing to treatment and virologic suppression. And of course, linkage, engagement, and retention are very important along this continuum, and you know, maximizing getting to reduced HIV infections. So in San Francisco, in addition to the universal treatment offer policy, we're implementing a lot of programmatic interventions to expand routine medical testing, increase community testing, partner services interventions, as well as all the ancillary support services that are integral to keeping people stably engaged and adherent to antiretroviral therapy. And we've been looking at the impact of what we've been doing over the past several years by looking at the median CD4 at diagnosis, the median CD4 at ART initiation, and percent virologic suppression in addition to our community viral load work. And two new things that we've been looking at is the time from diagnosis to ART initiation and the time from diagnosis to virologic suppression. So just using our surveillance data, we can see what's happening. So these results we presented at CROI earlier this year, but just to show you, it took an average of 32 months for people to go from initiating ART to virologic suppression in 2004, and that was down to 8 months in 2008. Looking at this another way, we went from an increase in suppression within 12 months from about 26% to 82% in 2008. Now, this graph on the left side is the people on whom we have viral load data, because if I didn't have their viral load data, I couldn't tell you if they got suppressed or not, right? Here is looking at that as a proportion of all people diagnosed in San Francisco. The numbers look significantly worse here because these are of all the people who were diagnosed, and on many of the folks who were diagnosed, we do not have follow-up CD4 and viral load data. So this highlights not only the importance of being able to use the data that we have collected, but also to do the retention and engagement and outreach efforts, and also to harmonize data across different systems, because many people are diagnosed in San Francisco and may move elsewhere within the country. So I just wanted to summarize that and say that it's a very exciting and hopeful time. We heard about a great many research and programmatic interventions planned in North America and elsewhere that's very exciting. We're waiting for those results. And while we're waiting, we can also look at our existing data to see what, how as people implement and disseminate the research findings that we already have, what's happening in our communities at the jurisdictional level. So thank you very much.
Okay, I think we're